Good afternoon. My name's Christine Collins. I'm a physiotherapist by background, and I currently work with Sydney North Health Network as a musculoskeletal coordinator for this project. And I'll let David introduce himself and then we'll get rolling.
I am David Grant-McGuinness. I'm a General Manager for Commissioning and Partnerships. I'm also a physio by background, actually. Yeah.
So it's our pleasure to be here this afternoon, and we're presenting our preliminary learnings from a current project in place in our region targeting musculoskeletal health. This project has really been a platform for us to realise some of the key local enablers for integration, which we believe can be applied more broadly. So the project that we're talking about is a 2-year collaborative pilot project in partnership with our local health district, as well as the New South Wales Agency for Clinical Innovation. This project actually started in the days of Medicare Local and has been transitioned through to today. There are 3 other pilot sites across New South Wales undertaking similar projects, Mid-North Coast, Murrumbidgee and Far West New South Wales. And they're all under the banner of the Musculoskeletal Primary Healthcare Initiative, which is there, which the ACI sort of supports all of us. And out of interest, some of our partners from Murrumbidgee are currently presenting in one of the other rooms, so you're not missing it. As a bit of background, so there were, amongst others, 2 ACI models of care which had been developed, one addressing hip and knee osteoarthritis and the other addressing osteoporosis. Both had been implemented in hospital settings across New South Wales, and I won't go too much into the actual models of care in the interest of time, but essentially both promote patient-centred care based heavily on the chronic care models and really reinforce the importance of having multidisciplinary teams wrapping around the patient. So the purpose of the project for each of the pilot sites was to trial the translation of these models of care which had been implemented in the hospital setting to primary care. And for our own site, our goal was really to build capacity and sustainability for primary care management of chronic musculoskeletal disease. So how did we do it? What did we do? What are we still doing? We developed a multidisciplinary project advisory group, which is not unique to any other project, but we had good support from all of our partners. So the local health district was there, as well as the Agency for Clinical Innovation, and we're very fortunate to have some really well-respected clinical leaders and content experts in our region, both GPs and specialist clinicians. We had some very engaged consumers and allied health providers, both public and private. And having the New South Wales Agency for Clinical Innovation, the Musculoskeletal Network, as part of our advisory group, allowed us to learn on the spot what other sites were doing and what had worked and what hadn't worked in other implementation trials. So, as well as myself, there are 2 other allied health professionals who are employed as musculoskeletal coordinators to basically facilitate the implementation of these 2 models in primary care. So in terms of what we're actually doing, there's sort of 2 streams to what we're doing. The first is tailored general practice training and mentoring to support 4 key activities. Really the identification of these patients through practice software, and then supporting the practice to undertake comprehensive assessments of these patients, usually led by the practice nurse in consultation with the GP, as well as case management, again usually through the practice nurse, and really the most important one is that multidisciplinary care planning. So each practice that we're working with has different requirements into what they currently do and what they need more help with, and we've allowed them to tell us what they need, which has been very interesting. There's so much variation. The second part is really the facilitation of localised referral networks to meet the client's needs, and that's something that it certainly wasn't the key focus when we started, but along the way we've realised that's where a lot of the work needs to go on to. So I'll let David cover off on that in a bit more depth.
Thanks. So it's become really evident to us that the general practices participating have built their capability and capacity to clinically assess and manage these chronic disease patients. And that's been through the support of the musculoskeletal coordinators. And that's a great result, so we're really happy with that. But what's been really interesting is that the general practices themselves have identified their own gap in knowledge, and that's their lack of awareness of the surrounding network of service providers. And they've identified with our facilitation that that's limited their ability to sustainably and holistically manage this disease patient cohort. And essentially that just means, great, we've assessed these patients, we're better at assessing, now what? So we all know that the evidence tells us that good MDT working produces better outcomes for patients. The success of these models of cares in the acute sector, in part, unsurprisingly, is due to a readily available provider network. Often the physiotherapist will be stood next to the specialist in the outpatient clinic, and there you go, there's your patient. General practice don't have that. We assumed that our general practices in our area, with a well-resourced provision of allied health and community providers, were utilising those providers, and that was inconsistent throughout the region. So this is kind of an overview of the project. And Christine's alluded, in the first year, there was a real focus on building capacity in general practice, building clinical skill, engaging patients, recruiting patients, working closely with the model of care. But then that's kind of self-limiting, really. So this next year, the work we're undertaking now is about building that network, which supports the remit of the PHN. So we've identified allied health providers, community services, and service providers, both public and private in the region. And what's been great is to give the general practices that tailored bit of advice. It's not rocket science. We've provided a couple of cheese and wine evenings. We've invited allied health practitioners to practice meetings. And we've heard GPs say, great, it's really nice to see you, pharmacists I've been referring to for 10 years. So we're starting to see that trust building of relationships, which is facilitating patient referrals and better patient outcomes. So we always talk in primary care about awareness and access issues, building relationships. So we're kind of earmarking this as real good purposeful networking this year for our general practices. And we've reflected quite a lot. We've had lots of reporting to the ACI, so it's been an ongoing evaluative process. But what we've really realised is, from an integrated care perspective, which is the stream of this discussion this morning, it's been really important to have good executive sponsorship from our partners. So our local health district and our PHN, and previously the Medicare locals, there's very good will from the executive for this type of project to thrive, really, as an example of good collaborative working. So that's been a real driver for the success of the program. In terms of the future, we're looking to see what the other sites will do. The ACI's big goal is to look at how we sustainably implement these models in primary care. We don't profess to have all of the answers, and nor should we. And indeed, as this project would continue, we would look to change it and to look what our colleagues have done elsewhere, which links into my area in the PHN of commissioning. And instead of rolling out just another project across the region, kind of looking at it much more strategically, identifying a need. And then just some practical implementations. There's clearly a need within our region for this type of work to be supported by clinical decision support tools in general practice, and push for shared electronic health records. And just to conclude, as a comment, when this presentation was positioned in the integrated care stream, it kind of forced us to reflect and say, are we doing integrated care? Is this good integrated care? What's the focus of this project? And I think over the couple of years, I think Christine and I can both reflect that initially we focused on the models. It was all about the clinical models. being a respiratory physio by background, musculoskeletal care was a bit painful, but well, God. But actually, the model doesn't matter, and that's what we've learned. It could be respiratory, it could be diabetes, it doesn't matter. What we found is keep it simple, build capacity in general practice, give them clinical leadership, empower them to be aware of their providers, build relationships, keep it nice and simple. So we're excited about the next step, so we'll tell you about it next time. Thank you very much.